you. So I sort of become a yearly topic for me to talk about ARDS, and this year Dr. Al-Jazmi sort of tried to keep me restrained to talking about sort of the ventilator and the management of the ventilator, which is what I'll try to do, and talk a little bit about oxygen delivery as well. Just as a disclosure, I am a consultant for the Michigan Hospital Association, Hospital Engagement Network, so I work on QI with MHA throughout the state, and I am a member of the ABIM Critical Care Board, but I'm not on the writing committee. I don't actually see critical care questions, but I can assure you that there's no special question that will come out of anything that I tell you today. Sorry. All right. So what I'm going to talk to you about today is going to just start with sort of an overview of ARDS and the definition, and talk about the Berlin update, which now I think all of you, I'm sure, are very comfortable with. Talk about physiology so that we can talk about some of the ventilation therapeutic options, and then review some ventilator strategies as well as oxygen delivery for patients with ARDS. Sorry, I am having trouble with my arrows today. All right. So ARDS has been described now for, I guess, exactly 50 years, since that was 1967 was when Dr. Petty and colleagues first described it in the Lancet as a clinical syndrome of severe dyspnea, tachypnea, cyanosis that is refractory to oxygen therapy, with loss of lung compliance and diffuse alveolar infiltration seen on chest x-rays associated with sort of diffuse alveolar damage on autopsy findings. And that was sort of the definition up until 1994, when the American and European critical care definition, which included the ideas that you needed an acute onset, compatible clinical history, bilateral pulmonary infiltrates, a wedge pressure less than 18, and an impaired PF ratio, which they described using terminology that hopefully we don't use anymore, of less than 300 being acute lung injury, and then less than 200 being consistent with ARDS. And this has all been changed, and I just want to go over sort of why these definitions sort of don't work for us. And so the first was just the idea that they didn't define what acute onset meant. They didn't say how acute is acute, and so that's something they wanted to, we fixed with the Berlin definition. The question of bilateral pulmonary infiltrates makes sense, but exactly what those pulmonary infiltrates need to look like was brought into question. So Dr. Rubenfeld in 1999, as part of what you all know as the sort of 6 ml per kilo study, when they were preparing for this, he brought a bunch of x-rays to all of the ARDS researchers with the NIH and just threw them up and said, is this consistent with ARDS or not? And so you could see this was one of the x-rays, which is not surprising to all of you that about 95% of the physicians in the room said, yep, that's definitely ARDS. But about half said that this was consistent with ARDS. And if that's consistent with ARDS, there's probably not a chest x-ray in the world that's not consistent with ARDS. It looks normal to me, but I guess was abnormal enough for about half of the docs who are our leading experts on ARDS. And then this idea that you need to have a wedge pressure of less than 18 has been brought into question based on another big study that you're, I'm sure, all aware of from the ARDS network, which was the question of using PA catheter versus CVP data to assess, to try to dry out patients with ARDS. And what they found when they took all the patients who had a swan placed, that 30% of them had actually had a wedge pressure greater than 18, even though 98% of these patients had a normal cardiac index. So these patients weren't clinically in heart failure, but still 30% of them, all the patients sort of from here forward, technically, if the definition you want to use is a wedge pressure has to be less than 18, then 30% of the patients we take care of every day and call ARDS actually don't have ARDS because they have a wedge pressure that's higher than 18. So clearly, there's not a number that we can use as the definition. And then finally, this PF ratio issue, one of the problems with it is that it's not actually mutually exclusive. So it's the definition that always said that a PF ratio less than 300 was acute lung injury but less than 200 is ARDS, which means technically, if you have a PF ratio of 100, you have both acute lung injury and ARDS, since they're not exclusive. And then it wasn't clear why this was, and so that the other part of it is that it didn't really say what is that a PF ratio on a nasal cannula, or is that a PF ratio on a vent and a PEEP of 20? And obviously, as you can see from this data, if you take patients and you go from a baseline and give them PEEP, their PF ratio goes up. We all know that. We see that every day. We take advantage of it when we have patients with hypoxemic respiratory failure. But if you don't have a definition, then you could meet that definition because you're not on PEEP, and then somebody else could try to meet the same definition by being on PEEP. So you have to sort of define what your standards are if you want to use a PF ratio to define ARDS. So all of that sort of led to the need for something different, and this is what the Berlin definition came to, and they tried to try to address those specific issues. So the first one was timing. So acute is now defined as within a week of a known insult or known clinical insult or new worsening pulmonary respiratory symptoms. So it has to be within a week. Most of us see ARDS, see it happen within a day, but within a week is sort of the minimum that gets you to acute. So bilateral opacity is not fully explained by effusions, lobar lung collapse, or nodules. It's pretty broad, but at least it's consistent. I mean, so somebody with bilateral pneumonia fits, right? There doesn't say not fully explained by pneumonia. It says not fully explained by effusions, lobar lung collapse, or nodules. So anything that's bilateral is consistent with ARDS. Alveolar hemorrhage is consistent with ARDS. It just has to be bilateral. It's the only requirement. And then the way they deal with the question of left-sided heart failure is just that it's respiratory failure not fully explained. Not fully explained by cardiac failure or fluid overload. So if you have somebody who's got an EF of 30% and they come in with pneumonia and you give them 5 liters of fluid and they have bilateral opacities, the question is that fully explained by their heart failure? If it's not fully explained by their heart failure, it's ARDS. It's an important conversation we have every day when we talk about patients for Rose. It's the issue of fully explained. So yeah, I think some of it might be heart failure. Fine. Is it all of it heart failure? If the answer is no, then it's consistent with ARDS. And they prefer some objective assessment if you want to really truly exclude hydrostamic edema if there's no risk factor present. So if you have somebody who just shows up with bilateral infiltrates, they don't have pneumonia, they don't have pancreatitis, and you go, gee, maybe it's ARDS, then in those patients you should get an echo and make sure it's not heart failure, which I think clinically we would all do anyways. But that is the only time it's required that you try to measure something about the left heart. Otherwise, there's no requirement for an echo or a wedge or anything else. And then finally, they sort of nicely defined exactly all of these patients. So everybody with a PF ratio of less than 300 has ARDS, and then they're just these mutually exclusive. If it's 200 to 300, it's mild. 100 to 200 is moderate, and then less than 100 is severe. Complicated a little bit by many of the things we talk about. We talk about patients being at high risk when their PF ratio is 150, which is sort of right smack in the middle of moderate, but the cutoffs are there and they're mutually exclusive, and it's pretty clear that what mild, moderate, and severe ARDS is. And I always like to put this up just to remind people that the PF ratio is pretty easy to meet. It's pretty hard to think of somebody on a ventilator who doesn't meet a PF ratio of 300. So again, if you have somebody on 40% and they have a PaO2 of 80, that's a PF ratio of 200. So it's right on the border between mild and moderate, in fact. I mean, it's really hard. I mean, you have to be on 30% with a pretty good PaO2 to not be consistent with the PF ratio of 300. So you'd have to have PaO2 greater than 90 on 30% FiO2. Most of the patients we ventilate have oxygenation that's worse than that. So it's pretty hard not to meet PF criteria, and this is, I always just, so to remember that on 100%, any PaO2 less than 300, and on 30%, again, any PaO2 less than 90 is consistent with mild ARDS. So not hard to meet the criteria. And this is just to show you that these criteria make sense. So again, obviously in the old criteria, you could see the difference between what was called acute lung injury and what was called ARDS. ARDS was sicker, but as you define it by mild, moderate, and severe, severe patients do worse than moderate, who do worse than mild. And that's true both in terms of mortality and in terms of ventilator-free days. So it certainly fits to use this as a classification scheme because it hits on, it's predictive of outcome. So this is sort of what we always think about when we think about the pathophysiology of ARDS, is you have to figure out what's going on in the alveoli, and the idea is that you have this inflammatory milieu that's leading ultimately to the hyaline membrane, and it's that hyaline membrane that impairs gas exchange and causes you to have problems with oxygenation. And then also there's capillary leak down here, which is what gives you obviously the typical opacities and the flooding of the alveolar space that we see as this inflammatory milieu is ongoing. The second part of that is something that's really been discovered more recently, which, as I'll point out later, may be helpful as we try to think about why some of our therapies seem to work for certain patients and not others, and why it's hard to come up with a unified recommendation on what to do with patients with ARDS. This was a study that was published in 2014, and what these researchers did, it's sort of a complicated idea, but basically the idea was if you take characteristics of, typically this is actually done with animals, and you say, are these two animals, bugs, whatever, in the same species, you can look at a variety of characteristics to say, are these characteristics clustering together in one species, or are they beginning to separate and you have two species? This is done in ARDS, and when they looked, they could say, yep, there's definitely two subgroups that are clearly different, and they called phenotype 1 and phenotype 2. Phenotype 2 are the group that you think of as your bad ARDS. So they're more vasopressors, more likely to be septic. They have a lower PF ratio, which is what I highlighted there on the bottom. The phenotype 1 have less of that, tend to have lower levels of things like IL-6 and IL-8. Not things that we do clinically. We don't typically think about patients this way, but as you're approaching patients at the bedside, certainly might be helpful as you think about, as I'll show you later, what to do with your PEEP. So this is a nice paper, a nice table from a paper by Niall Ferguson about sort of ARDS and how to think about different therapies. And this is what I've always used to think about how to go over with you. What do we do and why, and where does it come from? The difference this year is that we've farmed out a fair number of these things to your colleagues. So Syed will be talking about ECMO and prone positioning at some point, I'm told. And Jesse will be talking about neuromuscular blockade, and Ala has some topics as well around steroids and fluids. So I'm really going to concentrate on the ventilator and on oxygen, and not really talk about rescue therapies as much. I'll talk about APRV because that sort of fits. But I'm not going to be talking about what do you do when those techniques don't work. I'll really be limiting myself to this. And we'll start, as makes the most sense to me, I'm going to start here with non-invasive ventilation. So here's the first of your questions. A 56-year-old woman with pneumonia and a lactate of 4 comes to the ED. She's given 30 mLs per kilo of fluid in the ED, and her lactate normalizes. She started on ceftriaxone and azithromycin for community-acquired pneumonia. Her initial chest x-ray showed a dense right lower lobe opacity, but now also shows that she has some right upper lobe and left lung opacities. Respiratory rate's 24 in non-labored. She's normotensive but tachycardic, and her ABG on a 50% Vendi mask shows a PO2 of 95 and no significant respiratory acidemia. So, what do you do next? So, how many of you think she should stay on her Veni mask and without any changes? Which I would argue is probably what happens 90% of the time, but nobody wants to do that. Anybody wants to put her on high flow nasal cannula? 2 or 3? Who wants to put her on non-invasive ventilation? You guys have to vote for something. That's the rules. And who wants to intubate her? Most of you are doing nothing. So I would argue that the right answer is to put her on high flow nasal cannula, and that's based on the Florali study which was published in 2015. So this was a study where they had 310 patients that sound a lot like what I just described. PF ratios less than 300, PaCO2 less than 45. Obviously, patients who are hypercapnic frequently need non-invasive ventilation for other reasons. And they were randomized to standard oxygen therapy, high flow oxygen therapy with a high flow of 50, and then a non-invasive ventilation with pressure support to achieve a tidal volumes of 7 to 10 mLs per kilo. And what they found, when you looked at the population as a whole, there's not a difference in terms of the need for intubation, although you can see that there's certainly a suggestion that high flow oxygen does the best, but definitely once you get down to patients with a PF ratio less than 200, it's quite clear that the patients who got high flow oxygen did much better than patients who got non-invasive ventilation or standard oxygen therapy. In fact, if anything, the non-invasive did a little bit worse than the patients who got standard oxygen therapy. But this would certainly argue that for most of our patients with ARDS who have hypoxemic respiratory failure that is not requiring mechanical ventilation, that they should be getting high flow nasal cannula. And these are the secondary outcomes. These were all statistically significant. Their outcome was to show, that their main outcome they wanted to show was that patients who, was decreased intubations, which is what I showed you. This is, again, the secondary outcomes are also, again, only significant for those patients with a PF less than 200, but now we're showing mortality differences for those patients. So pretty clear if somebody's PF ratio, again, on not an ARDS defining PF ratio because it's not on a PEEP of 5, but a PF ratio of less than 200 on a gas, on a venti mask, really should be converted to a high flow nasal cannula based on these mortality differences. I mean, those are huge. 11% versus 25% for non-invasive ventilation. That's half. It's pretty hard. We don't see those kind of differences very often for the treatments we have for ARDS or anything else. So question number 2. Try to vote this time. Patient is placed on heated high flow with the following settings. She's on 45 liters per minute and has an FiO2 of 50%. She has a SAT of 100%, so the resident decides to wean the high flow nasal cannula to a flow of 20 liters per minute with the same FiO2. So you get a gas and the PaO2 is 50. So what is the PF ratio? So just to remind you, 20 liters per minute, 50%, PaO2 is 50. So is it 200? Is it 150? Is it 100? Yes. 100. Any other choices other than 100? So the answer is you can't tell from this data, and this is why. So high flow nasal cannula, remember, is defined typically as somewhere flows between 30 and 50 liters per minute. That very high flow that you have with high flow causes the fact that you don't entrain any room air. So all of the air that's being delivered to your trachea is what is coming out of the end of the nasal cannula. So the delivered tracheal oxygen is the same as the oxygen at the end of the tubing. When you are providing patients with normal, sort of regular nasal cannula that we all prescribe at 2 to 15 liters per minute, increasing flow causes less entrainment of room air. We're always delivering 100% oxygen, but increasing tracheal O2 is done by increasing flow of your nasal cannula, which causes decrease in entrainment of room air. And so what is the data that we have to support that? Well, this was a study I was happy to come across, published in 2013, where they took patients and they gave them oxygen, actually 3 criteria. They did non-invasive ventilation, which I'm not going to show you. This is either just a regular face mask or an Optiflow, which is one of the companies that makes heated high flow, and they provided 100% oxygen and measured tracheal oxygen. So tracheal inspired FiO2, and it was either at 45 liters per minute, 30 liters per minute, or 15 liters per minute in both scenarios. And you can see that for Optiflow at 30 or 45 or 30, you're delivering about 90%, which is probably the best realistically we are providing when we're giving 100%. But when you go down to 15, you're only providing 65. And so the math whizzes in the room, if you use a regular nasal cannula at 15 liters per minute, what do you think is your delivered FiO2? 60 plus 21. So it's 81, right? That's probably no worse than that, but no better. So when you're providing oxygen with heated high flow with 15, my scenario was 20, which is somewhere in between, which is why I said you don't know. But again, this is the FiO2 you get when you provide 100 pure oxygen at 15 liters per minute. The scenario I had was 50% oxygen at 20 liters per minute. So both of them were lower, and I don't know what you provide, but you don't provide what you think you're providing. You certainly don't provide what's on the EPIC flow sheet. And then this is showing you the same thing happens with a face mask, which you all know, because that's how you decide how much oxygen you provide by face masks. So the next question, you decide to improve her SaO2 by increasing the O2 on the high flow to 100% and keeping the flow at 15 liters per minute. So you haven't changed the flow, you just sort of changed it to a conventional nasal cannula. With that, the saturation only improves to 90%. You notice that the patient is breathing with her mouth open. So you decide to switch to a face mask with the same flow and FiO2. The SaO2 will likely improve. So you just didn't change anything, you have a mouth breather. You went from nasal cannula, high flow nasal cannula to Ventimask. Will that improve the SaO2?
No, I think it would stay the same.
Okay, anybody think it'll worsen? Jay thinks it'll worsen, okay. So, the other part of the graph that I didn't show you is that the gray bars here is what happens when the patient's mouth's closed, and the white bars is what happens with the mouth open. So the most unexpected result I can think of, which is if you breathe with your mouth open with a face mask, you get a lower FiO2. If you breathe with your mouth open with the nasal cannula, you get the same FiO2, at least with the high flow nasal cannula, which is totally counterintuitive, but here's literature, this is data. So, in fact, if you switch that patient to a face mask, you're going to worsen their oxygenation. One more time. Therapy we give every day. We should know how it works. So you're eventually ready to send her to F2 and want to place her on 6 liters nasal cannula. However, the resident states, well, we know she's a mouth breather. Shouldn't we try a face mask instead? So you reply, yep, that's right. We know oxygen delivery with a conventional nasal cannula is worse when your mouth is open. Nope, oxygen delivery is the same, or no, oxygen delivery is actually better with an open mouth using a conventional nasal cannula.
I know that there was a study that they looked at FiO2s and with nasal cannula with mouth breather it didn't change. So it doesn't really matter. It's the same. I shouldn't have asked.
I appreciate your honesty, Seth, because this is what, again, we all hear this every day on rounds, right? Let's take them off a nasal cannula and put them on a face mask because they're a mouth breather. Mouth breathers do better with a nasal cannula than they do if they're not mouth breathers. Why that is, I have no idea. I've never figured out the physiology of this, but this is the only data I've ever found that actually did the study to ask people, put a nasal cannula on them, check their tracheal FiO2, and then tell them to open their mouth and do it again. And at every liter flow, you get improvement. And you'll see that if you look at the numbers, it does sort of fit pretty well with our 4 per liter. So if you say, where do we get the idea that every time you go up by a liter flow, you get a 4% improvement in your FiO2? That's the sort of empiric data that supports that. So at least now we all know how to use oxygen. So let's go on to the ventilator. So obviously the first part of the ventilator is this big piece that we all agree about is low tidal volume ventilation. And that is basically the idea that in ARDS, you have these parts of the lung that are flooded and you have less normal lungs, and so you have sort of a baby lung is the way we think about it, and that with that baby lung we want to use smaller tidal volumes, because if we don't, we run into problems like this. And this is probably a better model for recruitment than it is for overdistension, but these are the studies that always showed us the danger of ventilator-induced lung injury and overdistension, where you take a rat's lungs and you expose it to a high pressure and hence a high volume, for 30 minutes, and you go from a very normal-looking, nice pink lung to this horrific thing that looks like liver, which you can imagine would be very hard to get oxygen in and out of. And that's why we know that we want to avoid ventilator-induced lung injury, and the ARMOR trial is the study that really did that, and as you all know, it showed improvements in all sorts of outcomes when you compared 6 mLs per kilo ideal body weight to 12 mLs per kilo ideal body weight. So whatever outcome you want to look at, it definitely was improved. And this is the mortality, just looking at it in terms of a Kaplan-Meier curve, showing the same thing, the benefit of lower tidal volumes as opposed to more traditional, what were called traditional tidal volumes of 12 mLs per kilo. And so the patient takes a turn for the worst and is intubated. You place her on the ventilator with the following settings. So she's on an FiO2 of 100, a PEEP of 5, tidal volume of 360, which is 6 mLs per kilo for her, and a respiratory rate of 18, and her PaO2 is 60. So who wants to keep the PEEP where it is, since her SAT's okay? Who wants to change her PEEP based on a low PEEP table? High PEEP table? Still have some believers. Good. Stress index? Thanks. And esophageal pressures? Nobody uses esophageal pressures. Anything else that I didn't mention that you all would do? And so I will say that I'm not going to claim that's the right answer, because I don't think we know what the right answer is. That's what I would do. But I have no idea what the right answer is. Yes?
Keeping in mind the JAM article.
It's coming.
This is before that.
Maybe. You could argue that, sure. Yeah, I hear you. So again, the idea of PEEP, the idea of why we want PEEP is that if we have a level of PEEP, although we run the risk of overdistension of a normal lung, we tend to open up the lungs that are recruitable and allow for better oxygenation with the capillary leak. And then we avoid this thing that we see in animals that we believe we see in humans, and maybe even the recent article that Jeff is talking about is an argument for this, is that you develop this idea of atelecta trauma, that the thing that harms a lung is repetitive opening and closing of units, that you're much better off having lung that is open and stays open rather than letting it open and close with each breath. You obviously do part of that by having smaller tidal volumes, but the other piece of it is you do it by keeping the lungs open by using more PEEP, and it's really based on the hysteresis, which we all look at in this curve. The idea that, if you have a lung, if you're down here, if you're ventilating the lung below whatever this lower inflection point is. So again, I always use a balloon to think about this. It always makes the most sense to me. If you think of a brand new balloon that you're just opening up, you push and push and push and push, and then the balloon opens, and when it opens, it's very easy to fill until it's obviously full, and then you get the bird's peak end, which is no matter how hard you push, you're not going to put any more air in because the balloon's full. And so the idea is, if you're below this lower inflection point, you're taking that balloon, letting it close, pushing it open again, letting it close, pushing it open again, and by doing that repetitively, you're causing some degree of cytokine release and cascade changes that are going to cause trauma to the lung. So you try to get a PEEP that's above this level, and you can do that in a number of ways, which is part of what I'll talk to you about, but then you ventilate up in here somewhere without getting way up here, which is where you end up with the volume trauma, which is we try to avoid by having low tidal volumes. And this was the meta-analysis. This is pre the JAMA article, but the JAMA article's in here. So prior to the recent JAMA article, there were 3 studies looking at high PEEP in patients with ARDS. None of the 3 of them had a significant outcome in terms of mortality, but when you put the 3 together and you limited it to, this is an old paper, so it talks about with ARDS, without ARDS. What this means is moderate to severe ARDS versus what we'd call acute lung injury. So what we used to call acute lung injury, now we'd call mild ARDS. If you exclude the patients with mild ARDS, you get a significant improvement in mortality by using a higher PEEP protocol. And if you look at the same distinction, so ARDS, moderate to severe ARDS, and looking at the time to unassisted breathing, it's quicker when you're using a high PEEP protocol in this meta-analysis. And then this was all thrown into question with the ARC trial, which is what Dr. Jennings was just talking about, published 2 months ago or a month ago, probably October, in JAMA. In this study, there's a couple of things that are important to remember about this. I don't know the right answer, but I can tell you what the things that I will bring up. If we could do this for a journal club and we could talk about it more. But the lung recruitment in this, so there's 2 parts to high PEEP, right? There's having a high PEEP and keeping it there, and then there's getting to a high PEEP. So some of the high PEEP studies that are in that meta-analysis just picked a PEEP level. So the alveoli trial that was done by the ARDS network just said pick a higher PEEP, which is what most of us do, at least most what I instruct you guys to do in the ICU, which is I say, okay, go up to a PEEP of 20. I don't say do a recruitment maneuver and then get to a PEEP of 20. I say just slowly get up to a PEEP of 20. That's what happened in alveoli. In the open ventilation study, they did a recruitment maneuver for like 30 seconds and then went to whatever PEEP they were going to go to. In this study, they said, well, we want to look at compliance at every level of PEEP. So they started at a PEEP of 40, did a volume pressure curve, went down to 38, did a volume pressure curve, down to 36 and did a volume pressure, did all the way down to 16 or down to 12. Then they did a whole thing while patients were intubated. They had a whole bunch of complications around just doing that recruitment maneuver. And then after they did all that, they said, yep, the best PEEP based on compliance is, on average it was 16, but it is whatever it is, and that's the PEEP they used. Very different, whether that's good or bad. As somebody who doesn't like to do recruitment maneuvers, I think it's bad, but I'm using data from my own biases, but that's what they did. And then they had the low PEEP, and they showed an increase in mortality. And it's hard to argue that high PEEP is good when not only did it not show a benefit, it actually showed harm. But there are a few things, again, I think do come up with the ARC trial. One is that prolonged recruitment maneuver. So their mortality within a week, which is not usually where we see increased mortality with ventilator studies, right? You don't usually see it early, you see it late. Early, there was an increase in mortality within the first week, which again would argue there was something about that recruitment maneuver that probably did harm people. They didn't do a good job, which every other study did, of saying, okay, if we're going to compare, this is, and if you guys remember, well, you probably don't remember, I remember, before we did the ARMOR trial, there were a whole bunch of trials that tried to look at low tidal volume ventilation, but they would compare 6 to 8 or 6 to 9. When you compare 6 to 8 to 6 to 9, you don't see a difference. When you compare 6 to 12, you see a difference. So if you compare 16 to 13 in terms of your PEEP, you're not likely to see the low PEEP do worse if the low PEEP's really not low. And that, I don't think, is a low PEEP based on most of the low PEEP tables. So it's hard to know whether the problem here is that you didn't have good separation and then you harmed people with the recruitment maneuver, but certainly could argue that it's just we shouldn't be using higher PEEPs, which...
Well, that might support the recruitment maneuver being the problem is that there was the other thing that was significant more than I remember is the barotrauma.
Yep. Yeah, there was a higher...
So maybe that's why
Yeah, and the other thing that was interesting was they were able to get really incredibly low tidal volumes, which is, I think, why they ended up with higher PEEPs in their low PEEP group, because they couldn't oxygenate them with these very low tidal volumes until they really pushed the PEEP up. So you just, again, getting some congruence, but again, you could certainly use this argument to say a low PEEP table or no PEEP table or whatever I want to do with the PEEP is as good as anything else. There's not good data that says you're wrong. And then there's the other thing, which is really talking about the importance of the driving pressure in terms of what the PEEP is doing. And so one of the trials that I'll talk about in a second is called Express. And what they did in Express is, what this study did is it took all the patients who were in the ARDS network trials and just sort of put them into characteristics. So you could have a characteristic like this, where everybody's on the same PEEP, but the driving pressures are all different. You could have this where the PEEPs are different, but the driving pressures are all the same. Or here where the PEEPs are all different, but the plateaus are all the same. And what you can see is the only thing that correlates with mortality, which is down here, is the driving pressure. So as the driving pressure goes up here, it goes up here. The plateau goes up, doesn't do a damn thing to the mortality. Here, the mortality gets better as the PEEP goes up, but not because the PEEP goes up, but because the driving pressure goes down. So really more about driving pressure, which again you could argue then to get the best driving pressure I need to know compliance, which gets us back to the same problem. But really looking at this data to argue that it's not about having the highest PEEP, it's about having the lowest driving pressure. And whatever you can do to get the lowest driving pressure is what should improve mortality when you're trying to deal with patients with ARDS. And then this is the other problem with using the meta-analysis, which is what I always pointed out. It's hard to argue that a meta-analysis is valid when 3 studies use 3 different protocols. I mean, it's hard to really say they're homogeneous, but just so you know that there are 3 protocols, this is what I usually pull up when I'm in the ICU, saying to the residents here, follow this. I usually will pull up the ARDS alveoli trial, which is this, and then you have a low PEEP and a high PEEP. And I would argue if you're not going to use the high PEEP, you could at least use low PEEP, so we'd all be using the same thing, but you could argue there's no data that that's any better than the one I make up on the fly every day, which is true. Then there's the open lung ventilation study, which not only do they have different than alveoli, they have 2 different ones, so you don't, which one do you follow? When we have patients on rows, we're following something that looks like that. The rows protocol looks a lot like the open ventilation study protocol. And then Express, what they actually did was they said, okay, we want a plateau of 30. We want the PEEP as high as we can get it and keep the plateau of 30. So basically, they're over here. They're saying, okay, I'm going to get the plateau to 30. If the patient's really compliant, I'm going to get a very high PEEP. If they're very stiff, I'm going to get a low PEEP. But I'm always going to get a plateau of 30. Different way of doing it again. And then obviously I just told you about the way it was done for the ART trial, which was a lot around recruitment maneuvers and looking at compliance at different PEEP. So part of the reason it's hard to argue that that we all should be doing high PEEP is that we don't even know what high PEEP is. But again, we're trying to get sort of above this in theory and below that. The atelectrotrauma thing makes sense. It's hard to prove, but it certainly makes sense. It's just hard to know how to get there and how to know how you're there. So one of the ways to know how to get there is to take that physiology and just take it on the bedside, which is to do a stress index, which I know you're all familiar with now. So again, the idea is you have a constant flow, and if you think about where you are, these 3 things, it's the hard part about this is to get this out of your head before you start looking at this. Because this is a pressure time curve, and this is a pressure volume curve, and they're totally different. So get that out of your head and look at this and say, what would happen if the lung is too closed? If the lung's too closed, the pressure's going to go up and up and up, and then it's going to curve down. Lung's too closed. What if the lung's too open? I'm going to be able to put air in, and then I'm going to get to where it's full, and then the pressure's going to go up much more quicker here. And if you're in the sweet spot, it's a straight line. So that's the idea, that if it looks like that, you will need to come down on your PEEP in theory. If it looks like this, you need to go up. And then you have things like this, which this one looks like you're too closed, and this one probably looks good. And as I'm happy to point out, although I love to do stress index, I do it at 9 o'clock when I'm on rounds, and nobody does it for 24 hours. How do I know that the PEEP I picked at 9 o'clock is good at 9:30? So that's the problem with this, but it's fun to do physiology at the bedside, so it's fun to do. So that comes up, what is the best way to pick? And I think this is probably the best data we have in terms of what's the best data to pick. So this is Dr. Gattinoni's group. What they did was they took a bunch of patients and they said, okay, here's a patient. What PEEP would I pick? And again, dividing patients into mild, moderate, and severe ARDS. If you use open lung ventilation, again, if you think about it, if the PF ratio goes down, your PEEP's going to go up, right? So you're always going to have the highest PEEP in the patients with the most severe ARDS, because it's all based on FiO2. You saw that. The PEEP goes up as the FiO2 goes up. For all of these other things, it's based on compliance, right? So Express, I told you, it's going to be as high as the compliance will allow you. doesn't correlate as linearly with mild, moderate, and severe. Stress index the same way. It's dependent on what you see at the bedside, and then you can use an esophageal Doppler. But again, that tends to do more with compliance than it does with oxygenation. So which of these is better? And what these researchers did is they took people with CTs, and based on CT, they graded how recruitable the lung looked based on what it looked like when the lung was deflated and what the lung looked like when it was fully inflated with some PEEP, and showed that the only thing that correlates really well with degree of lung recruitability, so if you believe that you should use higher PEEP on patients with lung that's more recruitable, which is hard to argue in terms of logic, clearly you should use some PEEP table that's related to FiO2 and not any of these other things, because there's really no good data that says you can figure this out based on doing what they did in the ART trial, which is doing a pressure volume loop at different levels of PEEP. So clearly it seems like the best predictor, the best way to pick PEEP is just to do it by FiO2, which is nice because we have that 24 hours a day, 7 days a week. It's easy to do. You just pick a table and stick to it. And then the other thing to point out, this is the phenotypes I told you about before, which we don't know what kind of phenotype most of our patients are, but you can see for patients with a low phenotype, for the phenotype 1, so the more mild ARDS, less inflammatory, less septic, patients who are treated with high PEEP in a variety of these in these two studies, alveoli and one other, the patients, if you take everybody with phenotype 1, the patients with low PEEP actually did better than the patients with high PEEP. If you take everybody with phenotype 2, the patients with high PEEP did better than the patients with low PEEP. So probably there's not a single answer for every patient with ARDS, which is what we'd like to believe. But if we have a surrogate, again, more phenotype 2 are the patients with more moderate to severe ARDS, which is, again, things that fit well with our PEEP tables. And then sort of the idea of, if you take this to its logical conclusion, if you like PEEP and you think PEEP's a good idea and you want to use a lot of it, if a little's good, then more is better, and we get to APRV, which is basically the idea that in theory, and totally in theory, we're keeping the pressure the same the whole time while allowing these releases, which allow these flows, but you're having these tidal volumes in between and then having these breaths when you're having a release. With the idea you're keeping the pressure, in essence, you're staying, if you think of that, the Bird's Peak sort of hysteresis curve, you're just staying right in the middle. You're not moving. You're staying right in the middle of that curve. You can't have volutrauma or electrotrauma because the PEEP's staying right where you want it. But it really is based on this, which I know none of us do. The theory of this, which I've tried to read Hibashi's stuff, and I still don't understand where he gets this number, but what he says is, if you start at peak expiratory flow, right, so you imagine you've done a release, if you will. You've gone from a PEEP of 30 to a PEEP of 0. The lung's going to exhale very quickly and hit some peak rate of exhalation, and then it's going to come back to 0. He argues that as long as the time, that if you pick the peak expiratory, when the flow is 60% of the peak, so if the peak expiratory flow was 10 liters a minute, when you got to 6 liters per minute and you stop there, the lung will not have collapsed at all. No alveolar units will have closed, nothing will have happened. As long as you stop there, you don't have any closing of a single alveolus. Not sure how he knows that, but that's what he knows. So he says if you know that number, you can then pick your T-low up here. You can see your T-low. You can pick it to be less than whenever that happens, and you're good. Except the reality is none of you do this, and I've never done this, and I don't think any of us know. We just pick a nice number, like half a second. We don't actually look at what the peak flow is or what the characteristics of that flow, because as he points out, there are times when the flow will look like that, and then there's times when it looks like that. Obviously, when it goes from B, big B to little b, you would have to decrease your T-low, because now you're hitting your number here instead of there. But we don't do that. So I don't think we can do this right. And then this is the part that really drives me crazy, is that he makes it, we know if we had a graph like this, and I showed you this, and I said, oh, I have a patient with ARDS, and I put them on a tidal volume of 10 to 15 milliliters per kilo, you'd say, oh my God, don't you read the literature? You can't do that. So here we're going from one pressure to another, right? We're going from a pressure, let's say, of 10 to 30. Here, because we say we're going from a pressure of 30 to 0, somehow that's better than going from a pressure of 0 to 30, which is all we're doing. We're just doing it in the other direction. But somehow this is thought to be safe, and this is thought to be dangerous, and I cannot, for the life of me, understand why they're different. And so I have a lot of problem with these typical release volumes of 10 to 15 milliliters per kilo, and then there's this whole idea that there are whole different kinds of APRV. So if you read an APRV study, some people will talk about fixed APRV, which is they just do what most of us do, which is we pick a T-low time, and you can see some of these times are awful long. I mean, I don't know how you don't get cyclic opening and closing if you have a T-low time of 2 seconds, versus sort of personalized APRV, which is what Dr. Hibashi talks about, but which you actually have to look at expiratory flows to find. So what I tend to do is say I'm going to avoid big tidal volumes, but I don't have a problem with keeping the pressures high, and as long as I can keep the carbon dioxide level okay, I'm perfectly happy to try to do this to keep my pressures high, because I do tend to think that mean airway pressure tends to correlate well with FiO2. That was shown in the ART trial, so the patients, like every other study, the patients on higher PEEPs with recruitment maneuvers definitely had better oxygenation. That's not helpful for all the comers. We know that there's a variety of interventions we have for ARDS that improve oxygenation that don't improve outcome, but when you have somebody of a PO2 of 50, it's probably useful to know what will get your oxygen up, and this will get your oxygen up. I don't think there's any question about that. All right. Jesse, what mode? So, sorry, just so this is flow. Oops, sorry. I keep doing that. This is flow. This is pressure. Okay, why is it pressure control? Okay, so it's probably not a volume ventilation. Why is it not pressure support? What? The patient's not initiating the breath? Okay. Yeah, it's certainly, I mean, when you look at the pressure, you don't see a clear negative deflection, so that's a good sign. If there was a negative deflection, what would you want to see to know whether it's pressure control or pressure support? So if each of these were triggered, so that's an easy reason why it's pressure control, but if they were all triggered, what would you want to see to know whether it's pressure control or pressure support? How's the flow different?
Flow being more like a no-light pattern.
So Dan can correct me, but I don't know that there's a difference in flow patterns between those two modes in general.
No, the only way you could tell would be the duration of the breath. And you could get some variance with pressure support, but not with pressure control.
Thank you, Dr. Ouellette. So, pressure control, we set an inspiratory time. You don't set an inspiratory time with pressure support because it's flow cycled, not time cycled. Right? So the only way you could tell with 2 breaths is if I gave you 20 breaths and you saw 20 and they're all the same duration, you go, that's probably pressure control. If they're different duration, there's no question it's pressure support. The other way you know is if you have breaths that aren't triggered, which is, I agree with you, is when I only show you 2, there's not a lot I can show you to know that it's not pressure support, but good. All right. So that is, then I want to talk to you about oscillation, because again, just like APRV, oscillation makes lots of sense, right? So if we're gonna worry about the idea of we want to avoid up here, and we want to avoid up here, and we don't want to pass either one, the best way to do that would be to pick something in the middle and stay there. And that's what high frequency oscillation does. It gets you you recruit what you want to recruit with some sort of a recruitment maneuver, and then you just hold there. You hold at 45 centimeters of water. The problem is, which is, I think, more evident, I think I've proven to you today, we don't know what we're doing with a ventilator in ARDS. It doesn't work. 2 studies, Oscillate showed it hurt people. Oscar showed it didn't help. Basically, no reason to use it. None of us use it. Shouldn't really be on your armamentarium of what you do with ARDS. Other than it paralyzes people for a prolonged period of time, I can't tell you a good reason why it shouldn't work. It seems like it should work great, but it doesn't. And so, that's what I have, and a few minutes to spare for questions. Yeah, Brian.
Sorry, Justin, since we're at twice today. I think we're still in the state of the art of ARDS management, and still do no harm on the patient could be themselves, right? I guess when I phenotype patients, I'm also thinking about the right part, in that if we know that oxygenation doesn't really change outcomes in any of these studies, maybe there are hemodynamic variables. And when I think about high peak and low peak, I'm worried about how much more right heart dysfunction I might be causing in a hypoxic patient. I might be biased by my own poor population, but seeing someone with PH get intubated and go to renal failure over 5 days kind of shows that next timeline for them. So yeah. I'm wondering if there's anything else that's come up in terms of pulmonary vascular dilatation that would ultimately make someone more hypoxic, but improve oxygen delivery, much the same way we do with cystoscopy. We know we're going to worsen shunt, but oxygen delivery would increase cardiac output and actually improve. We worry about if we can't fix oxygenation, that doesn't help people's mortality. Is it the collection of other organelles that we're using with the ventilator that really doesn't the NCU?
Yeah. No, I think your first point is totally on. I mean, I think the one thing I think I've learned in critical care is to be humble and to do, if nothing else, don't hurt people, because most of the time we don't know what we're doing, and we learn that what we thought we knew we were doing well, we were just hurting people with. And so that does make me nervous about PEEP. It makes me much more nervous in your population than it does in a general population. It's interesting. I mean, it's interesting that the nitric oxide studies actually show improvement in oxygenation, which you would argue they shouldn't. And I wonder about, inhaled prostacyclin or inhaled nitric oxide. I'm actually very interested in the idea of inhaled prostacyclin because it's so much so much cheaper than nitric oxide. But I don't know why it improves oxygenation, because it should worsen shunt, really. But it might make sense that could do 2 good things, and so maybe there is more of a role. I think it's a place that I haven't talked about. I think one of these guys is going to talk about nitric oxide, so it'd be a good thing to think about when we're there, because we think of it as somehow making VQ matching better, which is not really what it should do. But I totally agree that in your patient population, and maybe in more of our patients than we recognize, that we're causing problems. And none of you remember this, I'm sure. I remember the way we used to decide on the best PEEP was we used to put in a swan, and we checked not only an FiO2 but a cardiac output at every level of a PEEP, and we picked the best PEEP that caused the best oxygen delivery. So you were having your PaO2 go up and your cardiac output go down, and you picked where they crossed, and that was your best PEEP. We've never done that again, but it makes a lot of sense to say that is the best PEEP, and you can't make that distinction without thinking about the hemodynamic impact.
A couple of things that are interesting apropos to your comments are that it's not all about oxygenation. So when you look at the ARDSNet trial, and you look at the high versus the low PEEP, and you look at low tidal volume versus higher tidal volume ventilation, if you look at the specific data, the group that got low tidal volume ventilation had better mortality, reduced mortality, which is why we do it. They actually have worse oxygenation in the first day or so. So it's not all about oxygenation. Nitric oxide studies haven't shown that. The thing that you brought up is important, but I think it's worth mentioning that when you apply PEEP or airway pressures in a ventilator, you don't know how much of that is being transmitted in the vascular space because of changes in lung compliance. So even though we talk about high levels of PEEP and might worry about their effect on the right heart and on the pulmonary vasculature, you don't know, unless we do what we used to do, you don't really know what the effect is of that. And one of the interesting things about the EXPRESS trial, which is where they set a a
Plateau.
plateau pressure of 30 and just said as long as the plateau doesn't exceed 30, it's okay to increase the PEEP. The idea for that trial, which did show a better mortality with that method compared to low PEEP, is that as long as there was recruitable lung, the plateau pressure should not increase with augmentation of PEEP. And it goes to the idea that for me, about the compliance with the lung being different, and you don't know how much of those airway pressures are actually being transmitted.
But it was interesting reading the editorial to the ARDS study where Roy Brower sort of said, well, you know, we're working so hard to recruit this lung, maybe we should just leave that lung alone. If it's not easily recruitable, we shouldn't try to recruit it. I mean, and it does, I mean, it reminds me of why we got to 12 mLs per kilo, right? We got to 12 mLs per kilo because we said, gee, the CO2 is 60. That can't be good, let's get it down. Well, we do more harm trying to do something we think can't be good rather than just leaving things alone. And so, yeah, you wonder whether our goal shouldn't be to just deal with the lung that's easily recruitable, that doesn't require anything, and just use that. I mean, again, it's an open question. We don't know. Yes?
One of the questions I always have, and I think different ways to manage that, is how to differentiate from voice control to APRV. Because there is evidence, at least a few articles that suggest that when you transition from voice control to APRV, you usually target an ignorable at least to protect your peak from voice control, as opposed to by default ignorable zero, and that's what most of the articles do. You end up having teaching the APRV training where doesn't reality
Yeah, unfortunately, we have lots of, I mean, as I've read more about APRV and gone back and looked at our guidelines around how to use the APRV, it doesn't fit at all with how I think about using APRV. I don't know what I mean, again, Hibachi's articles have always been that as long as the T-low is short enough, he says your PEEP should be zero, just because then you have a consistent flow. You're getting the peak flow to occur, so you can figure out where that 60% level is. If you go from a pressure of 30 to a pressure of 10, the peak flow is going to be less, and so you have less time to allow the patient to exhale, is what I understand him to say. I can't say that I understand all of his logic. I look at APRV like, I think of it as pressure control inverse ratio ventilation, and that's the way I think about it, with the fact that we're using 2 CPAPs as opposed to sort of a fixed pressure that the patient can't augment. So I use pressures that I would use if I was doing PCRV. So I still use P-lows of 20 or 15. I don't use P-lows of 0 or 5 or 10. I use as high as I was using in volume control. So if I had somebody on a PEEP of 20 and 6 mLs per kilo and I wanted to switch them, I would say, okay, what's their plateau? Let's say it's 30. I would switch them I would go to a P high of 30 and a P low of 20. Not what anybody argues is the right thing to do, but that's how I would do it.
And it's also acknowledged that APRV was designed for, I guess, like population one that is like the also patients that don't have normal lung, and those patients make sense because of the role as opposed to patients who are
I mean, and there are, just to that point, there are positive studies clear about recruitment maneuvers and higher PEEPs for patients with normal lungs in the perioperative period. It's a very different population than what we're talking about. All right, I should let the 1 o'clock person start. Thank you, guys.